Now we come to a very important topic called hepatitis. What are the issues in hepatitis? How do you differentiate acute from chronic hepatitis? Histopathological changes. Where do you find balloon degeneration, etc., etc.? Bridging necrosis, piecemeal necrosis, we are going to talk about it. The second is alcoholic hepatitis, alcoholic liver disease. Everything, what is the spectrum of it histopathologically is another common issue in the entrance. Now let us quickly sort out the questions on hepatitis. In a chronic alcoholic, what are the important changes that you see in the liver? We find fatty degeneration, fatty liver is found. It can lead to chronic hepatitis, alcohol can lead to cholestasis, but granuloma formation is not a feature of alcoholic liver disease. So fatty liver, acute alcoholic hepatitis, chronic alcoholic liver disease and alcoholic cirrhosis is the spectrum of alcoholic liver disease that you come across. Have you heard of an entity called NASH? What is NASH, NASH? Non-alcoholic steatohepatitis. Those who are obese will have a little amount of steatohepatitis in the liver. Why fatty liver is very important for a radiologist? Always we treat patients, doctor, not reports. If you send any 40-year-old of your patients to a radiologist and ask them to do ultrasound abdomen, what will radiologist do? Okay, I will ask you a simpler question. If you have to write discharge summary as a house surgeon, in a case of let us say some little vomiting, somebody came, vomiting subsided and he is leaving home. If you are asked to write something in prescription, you will write multivitamins. So just the way physicians write that, what will radiologists write when they do ultrasound abdomen? Kidney normal, what else? Pancreas normal, abdomen normal, slight fatty changes in the liver, just like slight pregnancy. Then patient will go home, he will tell the daughter-in-law, see, don't think that I will live forever, slight changes are appearing in the liver, I am going to die shortly, take care of me until then. So then daughter-in-law will think, arey, this fellow will take care of home if I am going to office forever, he is going to die, she will come in panic to you. What is this, doctor, there is a fatty liver, my father-in-law is going to die or what? When is it Shubha Muhurat? Then you will, very common that patients will going to panic when they see slight fatty changes. So that's the reason don't give reports to your patients. Interpret them and show them. That's very important. Now, in alcoholic liver, what are the changes? We basically see fibrosis, hyperplastic nodules like this, which is very typical of alcoholic cirrhosis. Now, the third issue in hepatitis topic in pathology is autoimmune hepatitis. There are three types of autoimmune hepatitis. We are going to talk about it. And examiner's question of PGI December 2002 was autoimmune type 2. So you can expect type 1 in the next entrance, type 3 in the next year entrance. So a lot of things are yet to be asked. Autoimmune hepatitis is divided into type 1 and 2 and 3. Fundamentally the difference is they differ by steroid responsiveness if you treat them, and the serological pattern in the laboratory, there is a basic difference. If you look at the type 1 autoimmune hepatitis, you find anti-smooth muscle antibodies and entactin, ANA, they all will be positive. In type 2 autoimmune hepatitis, we find anti-liver kidney mitochondrial LKM antibodies are typically positive in type 2. Similarly, there is something called P450 ID6 which is positive in type 2, and synthetic core motif peptides 254 to 271, they are positive in type 2. Then in type 3, what is positive serologically? There is something called soluble liver kidney enzyme called LK. LK is typically positive in type 3, not LKM, LK is positive, and cytokeratins 8 and 18 are typically positive in type 3. So serologically they are different. Number 2, age. Pediatric population you see type 2, 2 to 14 years. Whereas adults 30 to 50 is type 3 and 10 years in type 1. Similarly, women, men differ. Classically, type 3 is female predominant 90%, and of course all 3 types of autoimmune hepatitis means females generally. If you take concurrent other autoimmune disorders, if you see, type 3 will have more concurrent autoimmune, SLE, etc. will be there, type 3 may. Then if you look at the gamma globulin, it is markedly elevated in type 1 autoimmune disorder. Similarly, is the immunoglobulin A levels are low or are they normal is another differentiator. Low IgA is a feature which is found in the case occasionally in type 2, not in type 1 or type 3. And similarly, HLA association is also different. And if you look at steroid responsiveness, a very good response is there in type 1 and 3, but type 2 has a poor response, though it is occurring in pediatric population. That is a sad story. And progression to cirrhosis, most important thing. At the end of doing all these laboratory parameters and identifying type 1, 2 or 3, the final prognosis you should tell the patient. So type 2 unfortunately has the highest amount of progression, 86%, they go into cirrhosis is what you need to basically understand. So in summary, autoimmune type 1 is the most common autoimmune hepatitis, and type 2 is seen in pediatric population leading to fulminant hepatitis and cirrhosis of liver, and type 3 is the one which has some very unique features. So that is an important thing you need to know about autoimmune hepatitis. That's all. Differences. Now, in chronic hepatitis, what are the classical histopathological features is a very important question. We see fibrosis of porta hepatis, we find bridging necrosis, which is the hallmark of the chronic hepatitis. Now what is important about chronic hepatitis? If you look at the architecture of liver, it is not disturbed, unlike cirrhosis of liver. Though it is chronic hepatitis continuing beyond 6 months, but still architecture is undisturbed, then you don't call it as cirrhosis, you call it as chronic hepatitis. Then the portal zones are infiltrated with lymphocytes and plasma cells, and there is a development of bridging necrosis, which is a very important feature of the chronic hepatitis. Now let us see the same in a better schematic. If you look at acute hepatitis, there is a reaction at the level of the bile duct, there is a ballooning degeneration, there is a development of hepatosis, periportal necrosis, and if it is hepatitis C leading to acute hepatitis, fatty changes will appear, and there is some amount of cholestasis. These are the essential features of acute hepatitis. So ballooning degeneration is a feature of acute or chronic, you are going to remember it as acute hepatitis. Whereas if you take chronic hepatitis, all these lymphoid aggregates will extend from the portal tract towards the central vein, and that lead to bridging necrosis and fibrosis, which is the hallmark of chronic hepatitis is what need to be remembered. Similarly, if it is hepatitis B, then it will lead to what are called ground glass changes in the hepatocytes, another important hallmark of chronic hepatitis. And there is an apoptosis. If it is hepatitis C, there will be fatty changes, and macrophages will aggregate if it is chronic. So these are all the important changes of chronic. If you look histopathologically, ballooning degeneration typically looks like this, and this kind of a ballooning degeneration is a feature of acute hepatitis is what you are going to remember.